Hello, everybody. My name is Monique Minnema. I work as a hematologist in the University Medical Center Utrecht in the Netherlands. And I'm very happy to present data of the Talquetamab study, which was an effort across the globe with several co-investigators. And we will present data, updated efficacy data and safety data from the MonumenTAL-1 study, which is a first-in-human study of Talquetamab in patients with relapsed and/or refractory multiple myeloma. And these are my disclosures. So Talquetamab is a GPRC5D anti-CD3 bispecific antibody. And what these antibodies do is that they bind both the myeloma cell, because the myeloma cells do express this protein that's called GPRC5D. And on the other side, they have a binding site for T cells. So when this drug is given to patients, the drug will bind to myeloma cells, but also will bind to T cells. And through this binding, there is activation of these T cells that are close by the myeloma cells. And this will help to kill the myeloma cells which have this drug attached to them. So that's a very elegant way, like an immunotherapy way to kill myeloma cells. And this drug has a name now. It's called Talquetamab, and it's a drug that is given subcutaneously. And we have treated already 130 patients in this trial, and we did not find the maximum tolerated dose. And that means that we could dose higher and higher, and there were no serious side effects seen in the first cycle. But we stopped with the increase of the dose because we already saw activity of this drug at lower doses. And at the moment, we are trying to figure out what is the best dosing regimen with the best dosing schedule for this drug. So in this presentation, I will show you data on safety, efficacy, pharmacokinetics, that's the way how the drug behaves in the body, and also pharmacodynamic data on two doses that were chosen for the phase 2 portion of this trial. And pharmacodynamic data are data that are involving T cell activation. So we can measure T cell activation in the bloodstream of patients. So with this trial, we included patients who had multiple myeloma that could be measured with an M protein in the bloodstream. They had to be relapsed and refractory and had no other treatment options available to them. And patients who had previous anti-BCMA targeted therapy was allowed. So BCMA targeted therapy is also used in bispecific antibodies or in CAR T cells, but also those patients could participate in this study. And our goal was to identify the recommended phase 2 dose, so RP2D, to include more patients and to look more at efficacy and safety, and also to look at the PK and PD data. So we had two dosing schedules, the 405 microgram per kilogram sub-Q dosing every week. So patients came into the hospital every week for this dose. And we had another dose with 44 patients included, in which we gave a double the amount of dose, so 800 micrograms per kilogram, and we administered that every other week. So once every 2 weeks, patients had to go to the hospital. For both for both dosing regimens, we do need step-up dosing. And the step-up dosing starts with a very low dose. 2 days later, the dose is increased, 3 and 4 days later, the dose is increased again. So we slightly increase the dose, and we do that to mitigate the side effects of cytokine release syndrome that is seen with all bispecific antibodies and also with this dose. So step-up dosing is something that you normally see when you study bispecific antibodies. So here are the characteristics of the patients. We had 30 patients in the every week dosing cohort and 44 patients in the every other week dosing cohort. The median age was 60 or 64. Many patients had extramedullary plasmacytomas. It was around 1/3. And also there were the median prior lines of therapy were 6 or 5. So these patients were heavily pretreated. What you can also see is that most patients were, of course, triple class drug exposed, but also some patients already were pentadrug exposed. So that means they had 2 different proteasome inhibitors and 2 different types of immune modulatory drugs like lenalidomide or pomalidomide. But also there were some patients who had a previous BCMA targeted therapy, and that was mostly ADC, so that's belantamab or another bispecific antibody, but also some patients who failed CAR T-cell treatment were included. The refractory status, that means that the patient did not respond anymore to the last line of therapy, was for the triple class exposed patients, nearly 80% of the patients, and for the pentadrug exposed patients, it was around 20-25%. So here you see the safety data. So what we did see in the first cycle, especially, were hematologic side effects, so neutropenia, anemia, lymphopenia, and thrombocytopenia. But overall, the most common adverse events that we saw were not hematological, but were non-hematological, and they were the cytokine release syndrome, and I will tell something more about that in the next slide, but also skin-related events, nail-related events, and dysgeusia were seen. And dysgeusia means that you have an altered taste, and in most patients, it means that they don't have any taste. So when you eat something, it tastes like nothing. So it's very difficult to maintain enough calorie intake if you suffer from dysgeusia. So what we normally did for dysgeusia, but sometimes also for the skin-related events and the nail events, is that we, of course, had supportive care, sometimes some dexamethasone in ointments or in fluids that you can put in your mouth. But also sometimes we had dose adjustments, so a lower dose or a less frequent dosing. The cytopenia is mostly resolved, and with all drugs that we use to treat multiple myeloma, we do see infections. So infections occurred in around 40 to 50% of patients, but were mostly grade 1 or 2, and that means self-limiting or antibiotics at home. But in some patients, there were grade 3 or 4 events, and that means that you needed IV antibiotics in the hospital. There were no deaths due to drug-related AEs, but it's clear if you look at the schedule that there were, of course, side effects. The skin-related side effects was something that we did anticipate with this drug, because that protein that's called GPRC5D, that is highly expressed on the myeloma plasma cells, is also expressed on the skin and on the nails, and also expressed perhaps on the tongue. So the side effects that we do see seem to be related to the type of drug that we are giving. So if you look at cytokine release syndrome, that means that if you give therapy that is activating your immune system, patients do report fever, chills, sometimes they have coughing, some dyspnea. So there is some, like you have an infection. So it looks like you have an infection going up, but it's not an infection, it's just the activation of your immune system. And with these 2 doses that we tested, we did see in around nearly 80% of patients that they did have some cytokine release syndrome. And also this cytokine release syndrome is graded. If it's grade 1, then most of the patients, it's just some fever that goes away without any measurements. But if you have grade 2 or grade 3 cytokine release syndrome, you need a drug that's called tocilizumab to get the fever down again and to calm the immune system down again. It's very easy to give tocilizumab, and it does not hamper the efficacy of this drug. So all grade 2 patients, of course, did receive this drug, but in most patients, it was just a low-grade fever that went away on its own. And here you see the results. So this is the efficacy of the drug. The median follow-up of the patients in the study is not that long. It's a year in the first dosing cohort, but only 8 months in the every other week dosing cohort. And we did see a very promising overall response rates in these patients. And you must appreciate this is a single drug, because in the beginning, we also used dexamethasone to dampen the CRS and side effects a bit. But later on, from cycle 2 onwards, we don't use any dexamethasone anymore. So this is really a naked drug in patients that are heavily pretreated, and we still see a single drug activity around 65 to 70%. And most of these patients also had a very good partial response or a complete response, so also deep responses. We did not see a big difference in patients that were triple class or pentadrug refractory, and the median time to first response was also quick. We saw that a median in 1 month. And also from my own experience, sometimes in most of the times, we already see the patients respond during the step-up dosing. It's not, of course, a very deep response, but already with the first dosing, we do see responses in patients. So this is really a very active drug. But what's also very important to patients, not only that you do respond, so your disease is in remission again, but it's also extremely important that it stays in remission for a long time, of course. And with this drug, we saw a median duration of response in the 405 every week dosing around 10 months. And in the every other week dosing cohort, we now have a median duration of response of 13 months. So around a year, the response lasted. But you do see in this graph, each line represents one patient. And you do see that there were some patients that went off study quite early, so they have this square. But you also see patients, for example, here, and this is only going to 70 months, but also here, and this is going to 25 months, that are already in the study for almost 2 years. So it's a minority, it's not for all patients, but we do have patients already in the study for 2 years. So that's really, really encouraging. So this is the pharmacokinetic data, and this graph just shows that with both dosing cohorts that we do have a stable high level of this drug in your peripheral bloodstream. So that's good. That's for us important to know if we look at other dosing regimens, for example, every 4 weeks dosing regimen. And this slide just shows you that there are indeed activated T cells in your bloodstream when we are giving this drug. So PD-1 is a marker of activation of T cells, and we do measure that in our patients, and that's of course something that we also expect. So our conclusion was that Talquetamab is a bispecific antibody that is directed against a very novel antigen on your myeloma cells, and that antigen or protein is called GPRC5D, and that it's demonstrated robust efficacy in patients with heavily pretreated relapsed refractory multiple myeloma. At the moment, both recommended phase 2 doses seem to be equally effective and equally safe. But of course, you can imagine if you're going to be on the study and you have to go into the hospital every week, that can be cumbersome. So I think the every other week dosing can be more convenient to patients. We do continue with the study. We are looking for new dosing regimen, for example, the every 4 weeks dosing. And the overall response rate was around 65 to 70% of patients. And at the moment, we are persisting with this study, but we are also looking at other studies in which we have a combination of Talquetamab with other agents, because of course, in the end, we want to go towards a response rate of 100%, so all patients can benefit from this drug. Well, thank you very much for all your attention. We would like to thank the patients who are participating in the study, their caregivers, the physicians and nurses in all the study sites, and all the study personnel that's involved in data collection and analysis. And this study was funded by Janssen Research Development. Thank you very much for your attention.